In this recording, I'm going to be discussing obstructive lung disease and lung cancer, which are respiratory disorders. Obstructive pulmonary disease is characterized by airway obstruction, and this airway obstruction is worse with expiration. So in other words, individuals affected by obstructive lung disease will require more force in order to breathe out air. So they'll have to use their accessory muscles of expiration more than what is considered normal. There also will likely be more time that's required in order to expire a given volume of air compared to normal. So the emptying of lungs is slowed. But what's seen with these diseases is the production of inflammation. And so cytokines will be present, so pro-inflammatory cytokines. There's going to be mucus production. There could be destroyed alveolar walls. In any case, these main factors are contributing to an obstruction, leading to a lot of difficulty with exhalation of air. Individuals are going to have an increased workload of breathing. They're going to have this mismatching of ventilation-perfusion ratio. And they're also going to have a decreased forced expiratory volume in 1 second. So that's written as FEV1. And you may remember from normal anatomy that the forced expiratory volume test is a test that can determine somebody's lung health, where they're required to breathe in deeply and then forcibly breathe out or expire as quick as possible. And so people with obstructive lung diseases cannot breathe out air at the same rate as those without obstructive lung diseases. This is very important for you to know is the unifying sign and symptom when we talk about clinical manifestations of obstructive lung diseases. Remember that a sign is something that's objective, something that you could measure. Whereas a symptom is more subjective. It's something that a patient would tell you they're experiencing. So the unifying sign when it comes to obstructive lung disease is wheezing. So it's the sound of air that's trying to escape. And you can hear this, so it's objective. The unifying symptom is dyspnea or shortness of breath. So this is where the patient would tell you that they're short of breath. Although there are different obstructive lung diseases that exist, the two common ones and the ones that we'll talk about today are asthma and COPD, or chronic obstructive pulmonary disease, which encompasses two conditions, emphysema and chronic bronchitis. So starting with asthma. Asthma is a type 1 hypersensitivity, as you might recall from last term. It's a chronic inflammatory disorder of the bronchial mucosa that lines the airways, and it causes this bronchial hyperresponsiveness. And the bronchial hyperresponsiveness is going to include bronchospasm and mucus secretion. And mast cells play a big role in this. So if we look at this image here, we have an antigen, so something that's going to trigger the asthma that enters the airway. And it's going to come into contact with our immune system. So you can see some of them have come into contact with these dendritic cells, others have come into contact with the mast cells, and the mast cells respond by releasing inflammatory mediators. And they do this by degranulation, releasing what they have within their cytoplasm. Some of these antigens are penetrating through that cellular layer where they'll continue to come into contact with our immune system, including more mast cells that will continue to degranulate and have effects such as increasing mucus production, causing airway smooth muscle constriction and the leakage of fluid. And all of this is going to contribute to the symptoms that somebody would have when they're experiencing an asthmatic attack. It's this hyper response to an antigen that in somebody without asthma, they wouldn't experience this, but in somebody that's sensitive to the antigen that they've breathed in, they end up with a variety of different negative effects. Asthma can develop at any age, but it's more, or quite common, I should say, in children. It's considered a familial disorder, and there's more than, I think, 100 genes that have been identified that can play a role in somebody's susceptibility and even how they respond to treatment. Risk factors can include genetics then, but also areas where you might be more exposed depending on your living environment, where you might be exposed to certain things that the airways are more sensitive to. And so, as already spoken about on the last slide, it's common to see expiratory wheezing as well as dyspnea, but a faster breathing rate, which we know is called tachypnea, is also reported in many cases of asthma. So let's look at what happens with progression of the asthmatic response. We talked about swelling and mucus secretion and bronchospasm. Some people over time can develop thickening of the airway walls because of the inflammation. And naturally, this is going to cause a resistance to normal airflow. In particular, it impairs expiration. So if we can't expire out all of the air that we should, it can mean that some air is going to be trapped within the lungs, hyperinflating the alveoli. And that's going to change our ventilation perfusion ratio that was talked about in an earlier lecture. It means that affected individuals have to work harder just to breathe. This can lead to states of hypercapnia. Hypercapnia, remember, is an increase in the amount of carbon dioxide that is found in the blood, and that's because if you're having more trouble with expiration, it means you're not able to breathe out the normal amounts of carbon dioxide that you should to keep your body in homeostasis. It can also lead to states of hypoxemia because of issues with our ventilation perfusion ratio, which could lead to respiratory failure in more severe cases. But there is quite a spectrum for asthma, and the degree and really severity that somebody will experience. We're talking about the more serious states here. But if we look at this image here, when we look at normal compared to abnormal, we can see that there is excess mucus secretion. There's also constriction, like look at the difference in the airway here. Hyperinflation of the alveoli because of that air trapping. You can see mucus plugs shown here. You can really see the constriction through here. And so thick mucus and swelling and smooth muscle spasming are all contributing to obstruction of the small airways, making breathing much more labored and expiration quite difficult. Okay, so we looked at this image here, and now we're going to add a little bit more into our discussion on asthma. Let's start from the beginning. Somebody's exposed to what is an allergen to them or an irritant, and they breathe it in. What are we going to see occur? Well, we talked about mast cell degranulation already, and mast cell degranulation will have a couple of different, numerous different effects. One is it's going to release what are called vasoactive mediators, and these vasoactive mediators are contributing to an increase in fluid production in the area by dilating vessels and increasing capillary permeability. So this will allow fluid to leave the vessels, and vasodilation will promote blood flow to the area. Mast cells, when they degranulate, are also going to release chemotactic factors. Chemotactic factors are released at a site of injury, and they will encourage or sort of alert the rest of our immune system to come on over and help. So I describe them as being like a flare gun that goes off at a site of injury, alerting other cells to where the injury is so that they know where to travel to. And so this is going to allow cells, in particular neutrophils, but also lymphocytes and eosinophils, to arrive at the area to help sort out whatever problem is occurring. Now, unfortunately, these events are not very productive in a positive way because they lead to the signs and symptoms that are associated with asthma. bronchospasm, vascular congestion, secretion of mucus, damage to the cilia, which line our respiratory tract. The cilia help encourage when you breathe in with or without asthma, when you breathe in something foreign, the cilia will work along with the mucus cells, the goblet cells, to help trap it and then encourage it to move out of your body, eventually up towards your throat where you'll cough to clear it, so preventing it from reaching the lungs. Untreated inflammation will lead to, of course, continued hyper-responsiveness to the allergen or irritant, but can also lead to damage that's irreversible, known as airway remodeling. And this is where fibrosis is evident and the muscle actually gets thicker, the smooth muscle. Epithelial desquamation can occur, and that's shown here, where this is really part of the remodeling. So we're talking the late asthmatic response versus the early, the remodeling of the airway that I described earlier. So unfortunately, we have all of these white blood cells here that are and immune cells that are trying to help, but they end up causing damage. And so just the presence of the cells that infiltrate the area can also lead to that airway remodeling and fibrosis. Another point to make here that further contributes to the damage that's occurring in those with untreated asthma include the release of toxic neuropeptides. Neuropeptides are really just groups of compounds that act as neurotransmitters that are found within the airway. Now, in those that have asthma, these neuropeptides can be broken down more rapidly by enzymes from inflammatory cells, and this can also contribute to that exaggerated bronchial responsiveness. Jumping back up to the top here and looking at the inevitable immune activation that would occur shortly after exposure to an allergen or an irritant involving interleukins and immunoglobulin E. Immunoglobulin E, these are antibodies that are produced by your immune system. So when you have an allergy, your immune system is in this overreacting state to the allergen, and it will produce antibodies called immunoglobulin E. And so these antibodies are going to be involved in the release of chemicals that contribute to the allergic reaction. And then your interleukins, you might recall that these are produced by leukocytes or white blood cells, and they're involved as well in the immune response. And they can also signal mast cells to degranulate. Now, moving on from asthma to talk about another obstructive pulmonary disease called COPD, chronic obstructive pulmonary disease. COPD is defined as being a common preventable disease that's characterized by airflow, persistent airflow limitation, and it's not fully reversible, and it is usually progressive. And we can say that this condition is associated with this abnormal inflammatory response that the lungs have to something that's toxic to it. And in most cases, majority of cases, it's tobacco smoke. If it's not tobacco smoke from somebody who's an active smoker, it could potentially be from living with somebody who is a smoker. In other cases, it could be related to occupational dusts and chemicals that people are exposed to. Nowadays, measures are taken to prevent inhalation. Air pollution, so depending on what area of the world you live in and spend most of your time. And if there is some sort of issue during gestation or childhood that affects lung growth, could be considered a risk factor for the development of COPD. But this is the big one. We will see soon that COPD includes two primary phenotypes. Remember, the term phenotype is to describe the actual physical characteristic, what somebody displays. And so the two primary phenotypes that frequently overlap each other when we talk about COPD are chronic bronchitis and emphysema. So both of those phenotypes are associated with an enhanced chronic inflammatory response within the airways that's due to exposure to, as already looked at, something toxic, a noxious particle or gas. Exacerbations and comorbidities contribute to the overall severity of the disease. We're going to start our discussion on COPD by looking at emphysema, and then we'll follow up with chronic bronchitis. Emphysema involves destruction of the alveolar walls, resulting in this abnormal permanent enlargement of gas exchange airways. And so it leads to the formation of what's called dead space. And so dead space is going to represent the volume of, we could say, ventilated air that is not going to be participating in gas exchange. And even though some air normally doesn't participate in gas exchange, this form of dead space is problematic. With emphysema, though, there is no obvious fibrosis evident. So in other words, we're not seeing thickening or scarring of the tissue. Emphysema is caused by a loss in elastic recoil and the structural integrity of the walls that make up the alveoli, but it could also be caused by what's referred to as an inherited deficit of alpha-1 antitrypsin. And we're going to be coming back to this because you need to understand the involvement of this in the development of emphysema. So we'll come back to that. Let's have a look at how smoking leads to the development of emphysema. Smoking is going to naturally attract inflammatory cells, and this is going to stimulate the release of elastase. That's an enzyme. What elastase does is break down elastin. Elastin is a protein that forms, it's the main constituent of elastic connective tissue. Now, under normal circumstances, the actions of elastase are inhibited by alpha-1 antitrypsin. So what is this substance? This is a protein. It's found normally in the lungs, and it helps protect the lungs against damage that would be caused by inflammation. But smoking is going to reduce its activity, which leads to destruction of lung tissue, leading to emphysema. People can be born, it's rare, but they can be born with a deficiency in this protein. Okay, so an alpha-1 antitrypsin deficiency. And those affected people are more likely to develop emphysema and to do so at a younger age than is considered normal, so even in their 30s or 40s. So that is a rare deficiency that is really the only known genetic or inherited factor that will increase somebody's risk of developing emphysema. But if we look back up here, what we can see is that smoking in and of itself decreases alpha-1 antitrypsin activity, in addition to the attraction of inflammatory cells. The two types of emphysema that we'll speak of are called centriacinar emphysema and panacinar emphysema. Centriacinar is seen more commonly in smokers that have chronic bronchitis. And if we look at this example here, compared to normal, so we have our respiratory bronchioles, and then we get into the alveoli. You can see that the respiratory bronchioles in this example are quite enlarged. But overall, the alveoli have been spared. In panacinar emphysema, This is going to be seen more likely in older adults, also more likely in those that have a deficiency of that alpha-1 antitrypsin. If it helps you remember that prefix pan refers to all, that's its Greek origination. And so it's affecting all these structures rather than just the respiratory bronchioles like we would see with centroacinar. Think of pandemic as well. Pan is referring to all. It's affecting all countries all over the world. Now moving on to talking about the other component of COPD, which is chronic bronchitis. Chronic bronchitis involves bronchial inflammation commonly caused by smoking, and this inflammation is going to lead to an increase in the amount of mucus glands that are present, and they produce more mucus, and it's a thick mucus, and this can lead to a chronic cough. The actual definition of, say, chronic bronchitis versus acute bronchitis is hypersecretion of mucus and a chronic productive cough that is persistent for at least 3 months of the year and for at least 2 consecutive years. So this could be one of the first indicators of lung damage for those that are suffering from it. So we talked about mucus accumulation, and mucus accumulation means that in order to remove it, you need to cough, but sometimes coughing doesn't remove it. It's not enough. And so what can occur then is a mucus plug. And so what we have represented here are the bronchioles, and then we have an alveoli. And this mucus plug isn't really an issue when you're moving air in during inspiration because the airways are pulled open, allowing gas to move past the obstruction. The issue is during expiration. During expiration, there's this reduction in normal elastic recoil of the bronchial walls, and it leads to this collapsing that you can see of the bronchial walls, or collapsing of the airways, and that's going to prevent normal, really outflow of air through expiration. And so what we can see occurring here is this hyperinflated alveoli due to air trapping. And this can lead to a chest that is hyperexpanded due to this hyperinflation. And so these people will be dependent on bronchodilators, which are inhaled in order to help keep these bronchioles dilated. So I'm sure you can really appreciate the difficulty in expiration that has been mentioned since the start of this lecture. These individuals will oftentimes naturally start to exhale with very pursed lips, and this helps prevent that expiratory airway collapse that you can see happening here. In addition to taking bronchodilators and pursing lips to prevent that collapse, it's not uncommon for these affected individuals to rely on taking expectorants or cough medicine to help expel that excess mucus. There's also a ventilation perfusion mismatch that occurs with those that have chronic bronchitis. And this brings us back to a couple of images that we've looked at in this course already, where we have normal ventilation perfusion ratio and then a very low ventilation perfusion ratio. And why is this happening? Well, here we have blocked ventilation. So the example could be a mucus plug that we know occurs with chronic bronchitis. This mucus plug can cause the alveoli to collapse, leading to a very low ventilation perfusion ratio that's called a shunt. And so what we have happening here is deoxygenated blood, because it's not getting oxygenated because of this collapsed alveolus, is going to be mixing with oxygenated blood from a healthy alveolus, leading to a state of hypoxemia. And when we start getting this degree of damage to the lungs, it's not reversible. And this environment that occurs with chronic bronchitis does put somebody's risk of infection up as well. So we know that COPD consists of these overlapping conditions called emphysema and chronic bronchitis. And in one of our earlier lectures talking about heart failure, we looked at the development of cor pulmonale and right heart failure. And right from the beginning, one of the causes of heart failure, right heart failure, can be COPD. And at the time when we reviewed this flow chart, you didn't know much about COPD, but now that you do, you can apply what you know about it to the development of right heart failure. And so I'm sure you've already noticed that there is quite a bit of overlap between the cardiovascular system and the respiratory system, which means that the disorders overlap as well. So again, this is a repeat slide that we've already covered. Here we have a summary of COPD, and if we start at the top, some sort of irritant, with tobacco smoke being the main irritant involved in the development of COPD, is going to cause inflammation of the airway epithelial tissue. This naturally is going to create an immune response that's going to involve infiltration of various different inflammatory cells. We have our resident macrophages, and then we're going to release cytokines and call over neutrophils, other macrophages, lymphocytes. Leukotrienes and interleukins will also be released, all mediating this inflammatory response. And depending on the extent of the inflammatory response, it can lead to systemic effects, such as muscle weakness and weight loss in those that have pretty extensive inflammation. Now, from what we've already talked about, we know that these irritants can end up inhibiting normal endogenous means produced within the body, antiproteases. And the antiprotease that we spoke about is the alpha-1 antitrypsin. And so inhibition of this, or just a natural inherited deficiency, is going to cause or promote the breakdown of the elastin that is found as part of the lungs. And this is a big contributor to emphysema, where we have that destruction of the tissues and loss of that elastic recoil because of this breakdown. So that brings us to the emphysema component. In terms of the chronic bronchitis, the inflammatory response leads to this chronic state of bronchial irritation and inflammation, leading to the diagnosis of chronic bronchitis, where we'll see certain things such as fluid accumulation in the tissue within the lungs. We're going to have hypersecretion of mucus. You can be predisposed to infections, and so in those cases, bacteria, for example, can colonize in the airway. But in both cases of chronic bronchitis and emphysema, which commonly occur together, we are left in a situation where the airway is obstructed. Air can be trapped, and so we end up with this loss of surface area that's available to exchange gases. So that is carbon dioxide and oxygen. And we've talked about bronchospasm occurring and predisposition of infections, shortness of breath, cough, low oxygen in the blood, high carbon dioxide within the blood are all clinical manifestations that relate to COPD, as well as cor pulmonale, as already discussed. So if we go over here, we can see that COPD can lead to a state of acidosis. And what contributes to that with our low oxygen in the blood is the high carbon dioxide that's found within the blood. We'll also see high hematocrit levels in a lot of cases. And the reason for this is because the body is starving for oxygen. And so it thinks, okay, well, if I make more red blood cells, and that's relating to the volume of red blood cells, hematocrit, if I make more red blood cells, maybe I can pick up more oxygen. And so that is called polycythemia, an increase in the normal amount of red blood cells. And what this can do is make the blood really thicker. It has a greater density of formed elements, and this can predispose somebody to a variety of different concerning conditions, which include stroke. Now we're going to have a look at lung cancer, and we've talked a little bit about it during our cancer lecture in Altered Physiology 1, but we're going to bring it up again because of its relevance. Lung cancers are also known as bronchogenic carcinomas, or at least most are, because they are tumors that arise from the bronchial epithelial tissue of the respiratory tract. The most common cause, which won't surprise you, is tobacco smoking, and approximately 10 to 15% of active smokers will develop lung cancer. Now, the development of lung cancer involves a multi-step process of genetic and epigenetic and environmental interactions that result in dysregulation of things such as our oncogenes and tumor suppressor genes, where we activate these cancer-related signaling pathways. Now, although there are many types of lung cancer, they are divided into two major categories: non-small cell lung cancer and neuroendocrine. And this is based on cell histology. So what you should know, I want you to be aware of, is that non-small cell carcinoma accounts for about 85% of all lung cancers. Okay, so this is the big one. Now, what I also want you to be aware of is that the two main types of non-small cell carcinoma is squamous cell carcinoma and adenocarcinoma, with adenocarcinoma being the most common. So I'm going to rephrase that. Of the different types of lung cancer, bronchogenic carcinomas are the most common. Of the different types of bronchogenic carcinomas, non-small cell carcinomas are the most common. And of the non-small cell carcinomas, adenocarcinomas are the most common. Remember that the term adeno is referring to glandular tissue, so this is cancer of glandular tissue. Let's have a look at the image here to show you the more common location of these different types of lung cancer. In this image here, referring to squamous cell carcinoma, you can see that it's located more centrally, closer to the hilum, which is this region here, the hilum of the lung. Whereas adenocarcinoma is seen in the periphery of the lung. So you should be aware of those differences. To finish up this topic, we're going to look at the staging of lung cancer using the TNM classification. Remember, the T stands for tumor, the N stands for node, and the M stands for metastasis. So I'll just write that with my pen. So TNM classification. Now in Altered Phys 1 in the cancer lecture, we did look at this a little bit, but we're going to be applying it now specifically to the lung. We applied it more to breast cancer. And we're going to look at the different stages and what we typically see involved. All right, so now stage 1, you can see there are different examples. Somebody can be diagnosed with stage 1 where they have T1, so here is the tumor size, but no lymph nodes, and of course no metastasis. We wouldn't see metastasis until stage 4. In another example of T1, they can have the tumor present, but also lymph nodes that are involved on the ipsilateral, so same side hilar region. In another example of stage 1 is T2, so this is where it's larger now in size, but there is no nodal involvement, and of course no metastasis. Now in stage 2, still no metastasis, but this is where you have the larger size at T2 and there's nodal involvement, which you can see, but still ipsilateral. Now with stage 3, this is going to include all tumors that are more extensive than T2, or there could be a tumor that now has spread to lymph nodes more in the mediastinal area. So here you can see the difference here compared to here, or lymph nodes in other areas in the area are now affected with cancer. And then stage 4, that's where we're getting into true metastasis or spread to other organs. Okay, that is the end of this lecture. Thanks for your time, and I hope you have a great day.